It's a great pleasure to be here in Bahrain, and I would like to tell the audience that I'm basically a physician and a gastroenterologist, so I'm sure you're looking forward to some exciting surgical interventions later. I'd like to also thank Dr. Zahra and Dr. Fernandez for having invited me here to speak to you on what is a common epidemic currently, if I can use that word, in the Middle East, and what are the approaches of medical management to obesity. Now, obesity is well being recognized many years as a potential medical threat. And if you look at this cartoon, which was a reprint of the fattest man in America, I think it was very clear a long time ago that to be obese has definitely a lot of medical problems, and we have realized that over the years to come. Now, what is obesity from a common layman's term is obviously clear that if you're overweight and you actually gain weight more than you should. But what is interesting is the fact that we have now been able to objectively stratify obesity based on the body mass index, which is clearly calculated based on a weight in kilograms divided by your height in meters squared. And this was based on a normogram, which was actually extensively studied worldwide. And if you look at the classification, what is important is to look at a healthy weight of a BMI less than 18. And if you have a BMI between 25 and 29, you definitely consider overweight. And beyond 30, we then grade it into grade 1, grade 2, and grade 3 obesity. And this is actually an objective parameter to be able to actually help the physician, a tool to actually assess intervention before you actually look at surgical options. Now, these are the classical guidelines, and these are the NIH guidelines, which have been used extensively in Northern America, basically stratifying again the overweight individuals based on a BMI. But what I would like to emphasize is the fact that in Asian populations, and especially in the Middle East, it's important to look at the hip-waist ratio because of the fact that most normograms have been derived from Western populations, which may not be directly relevant to populations in the Middle East and especially in Asian communities. So it's important to take that and sub-stratify these patients with obesity and actually measure the hip-waist ratio, which are clearly important indicators of obesity. Now again, the degrees of obesity is very clear. You have a morbid obesity beyond 40, and these indications have been shifting over the years, and you probably will hear this later from my surgical colleagues. Now it is, as I mentioned earlier, an epidemic, and it's probably, if you look at the WHO estimates, there are close to 72.5 million deaths annually from obesity-related illnesses, which is phenomenal. And most importantly, if you look at the childhood obesity, 5% of obese children go on to become adult obese individuals. Just to recap, the prevalence is phenomenally increasing over the years, and especially across all BMI categories. This is an interesting study published a little earlier in Gastroenterology, and that as a potential target for treatment has gone out of vogue. And this is also again very clear in this study. Looking at fattening foods actually increases leptin resistance. Just to again recap, there are two focuses where one can actually look at, where is ghrelin, which increases appetite and increases body weight, as compared to leptin, which actually increases weight loss. Now, it's all exciting to look at an intellectual debate about the cause and the etiology, but the primary origin of obesity is basically bad eating habits. As we understand in the Middle East, it is extremely clear that children are unfortunately not trained to have proper food discipline, intake of high-calorie intake foods, fast food, McDonald's. And interestingly, I was reading an article yesterday that KFC has the largest outlets of Kentucky Fried Chicken in the Middle East. And the phenomenal increase is directly responsible for obesity and as far as the eating habits. Now, there are, of course, certain selected medications which impact obesity. If you look at the antidepressant drugs, and it's important to take a good history to see whether there are some correctable causes which contribute towards weight gain. So, in some way, it's important to have a good clinical evaluation. And as physicians, prior to planning an intervention, it's important to rule out possibly endocrine causes, have an objective measurement of BMI, categorize and stratify risk, and then look at treatment. Now, from a practical perspective, it is very clear that therapeutic interventions are a lot easier if you have early phases of obesity. So all the conservative medical management can focus on grade 1 and grade 2 obesities, that is basically BMIs less than 30. But as you go higher up beyond 30, you have to look at serious surgical intervention as a long-term cure for this metabolic disease. Now, it's important to also outline certain simple goals, and this is something the responsibility of physicians, to be able to sit and develop a relationship with patients, to explain to them clearly that you need to have a goal setting in the initial phases, and then look at maintenance on a long term, because these are the challenges to actually medically manage obesity. Now, diets, I just want to talk about the fact that they've just become an industry, a food industry, as you all are aware in the Middle East. It's very fashionable to have a whole number of diets which actually will promote weight loss, and the industry thrives on promoting these kinds of dietary regimens. But what is important is to understand it's not about what diet that you can actually recommend. Most diets are equally effective as long as you are able to restrict calorie intake. And that is an extremely important challenge. So across the board, if you review the literature, it is not about the diet, but the calorie restriction, the proportion of carbohydrates versus fats to ensure that you have a fat intake of about 30%, and the energy is driven primarily by 30% fat rather than carbohydrates. Now, what does this do to obesity in the long term? It's all exciting to look at it in the first phase. If you just look here, in the first phase, you have a tremendous response. Usually in the first 1 year, patients are extremely very happy. They come back saying, "Doctor, we've lost a lot of weight. I'm feeling great. I'm feeling a lot healthier." But the challenge is after that, for the next 5 years, most dietary interventions fail because of the fact that patients are not able to maintain the same kind of dietary discipline, and over periods of 3 to 5 years, regain their lost weight. And this is something we see in our practice on a routine basis. Now, behavioral therapy, Dr. Ivar had stressed the fact that it is important to have a team management. And this is where psychiatry and counseling and relationship building with patients are so critical. That you have to understand that depression and various other anxiety disorders drive obesity in a big way. Exercise. This is again very fashionable to be able to promote an exercise. Gyms and health fitness centers are growing by the numbers. But what is critical is to ensure that you do exercise on a regular basis, at least 5 times a week with a cardiorespiratory exercise lasting about 30 minutes, and encouraging lifestyle changes. And this is a challenge in the Middle East. Geographically, with the climates that we have, outdoor activities and exercises are restricted to certain periods of the year. And these are other challenges which are unable to maintain. Medically, there are a couple of drugs which have been approved, Silpetramine and Zenical. Zenical used to be an exciting drug, and as gastroenterologists, frankly, it has failed in many ways because patients are not usually happy with the drug, socially not acceptable. You have patients who have foul-smelling stool, and at the end of the day, it is not really effective in the long term. It is possibly a short-term solution. Now, Silpetramine has also been advocated primarily in the United States, but again, it has a lot of side effects: hypertension, increased heart rate, and also certain contraindications on valvular heart disease. So where do we stand here? If you look at the first 3 to 6 months, it's fantastic. Patients are extremely happy. They lose about 5 to 10% weight. Everything is hunky-dory. But as you go into the maintenance phase, this is the most critical element. When you say maintenance phase, it's an indefinite phase. Lifelong changes in your cultural way of looking at food, and discipline, which is another big challenge. So what happens is that when you stop treatment, patients get the disease back. Literally speaking, most of these symptoms come back, they regain weight, and then one has to look at some other options. Now, briefly talk about the step care management. It's all great to look at lifestyle intervention, hypocaloric diets, and this is what we do for a living. But does this really does it make any difference to the quality of life of patients in terms of obesity management? And this has been why centers like Professor Dilleman's center in Belgium has promoted a kind of a multidisciplinary center which basically interacts with a whole lot of physicians and surgeons and dietitians and psychiatrists to build up a comprehensive center to really make this an effective change in the metabolic profile of patients. Now, as a gastroenterologist, I'm very tempted to talk about the intragastric balloon. Frankly speaking, I'm quite disappointed with this procedure. We did introduce a lot of these balloons a few years ago, but most often these have failed after a period of time. And in this part of the world, it is a disaster, literally speaking, because of the fact that most intragastric balloons don't last beyond 6 months. They have to be changed. You lose patients after that. There's poor follow-up. And routinely you have patients coming back saying, I had a balloon 2 years ago, and it's still in my stomach and I'm gaining weight. Now, this was again emphasized with this Belgian study, and I thought I'd put up this for the sake of my good friend and colleague, Professor Dilleman's, because it is a great honor to share the same platform with him. And this is a study from Liège, which is not the most favorite part of Belgium, especially the West Flanders, where they saw that there was a failure rate of close to 44 patients. And the study concluded that the balloon is not suitable for obese patients. Now then, our endoscopic colleagues got excited about what the surgical colleagues were doing, and they said, well, why can't we replicate the same surgical procedures endoscopically? They are less invasive, more acceptable, and possibly may do the same things. And there was some exciting work. If you look at the endosage suturing device endoscopically, this was promoted by Fogan in 2008. All exciting developments. You decrease the volume of the stomach non-invasively, and you're trying to achieve the same result. Unfortunately, on a long term, these are still not accepted standard of care treatment, primarily because of the fact we still have to have a lot of studies which need to be done to see whether these actually work, and currently now not accepted. Then the Jean Pivier's group in Brussels in 2008 looked at the TOGA procedure, which is again an endoscopic vertical gastroplasty. Again, a failure in some sorts because they don't have enough numbers and it's still not recommended. Then Young and colleagues looked at a similar procedure endoscopically, to put a Teflon endoscopically to achieve the same surgical gastrojejunal bypass. Again, not enough numbers. So finally, last year, what they concluded is that no single endoscopic procedure is as effective as traditional surgery. So what is really important is to have the gastroenterologists and the surgeons to work together and look at combination of such procedures, whether it's an endoscopic balloon which is given up, or is it a banding, or is it a jejunal bypass. And this was important to understand that there are certain classical criteria which we understand now. You have a BMI above 40, but what I really want you to focus on is the fact that it has to be a multidisciplinary approach. You have an internist, you have a surgeon, you have a nutritionist, and a behavioral therapist to actually look at a dedicated obesity center, which is very similar to what Professor Dilleman has approached. Now, I won't go over this. We know gastric restriction procedures, intestinal malabsorption. We're all excited to listen to Dr. Dilleman's and also life surgery. But what does it do in terms of treatment success? Again, very clearly that either conservative lifestyle modifications or pharmacotherapy has limited success over a long period of time, 5 to 15%, but most often surgical therapy is probably the only way forward in terms of seriously reducing the complications of obesity. And this has again been exemplified by this paper by Professor Dilleman's, clearly looking that you have to combine certain procedures. You can do a lap banding with the gastric bypass in severely obese patients. And you need to be aggressive, you need to be brave, like Professor Dilleman. And as physicians, we don't have that, to be able to actually do surgeries with such high morbidities and high risk of mortality. But interestingly, bariatric surgery definitely reduces overall mortality. If you look at the study, they looked at 2010 patients. And if you look at the overall mortality, close to 30% reduction, which is quite phenomenal. And that is what has woken up the surgical community to look at bariatric surgery as a serious option. What does it do to cardiovascular risk across the board, whether it is hypertension, dyslipidemia, diabetes, sleep apnea? There's a dramatic reduction in all the comorbidities, which is again a very strong argument that we have to look for surgical options. Physiologically, because as physicians we want to see, is there an objective parameter? What does bariatric surgery do to do with the metabolism? And it's clearly been identified that ghrelin levels, which is so important physiologically for feeding and satiety, is quite dramatically reduced in patients who undergo a gastric bypass. So in conclusion, ladies and gentlemen, I'm sorry to kind of prolong my talk, but I thought it's important to understand that there are certain limitations as physicians and gastroenterologists. We can recommend diets, we can talk about exercise, we can talk about behavioral modifications. But at the end of the day, there are no magic bullets. And we have to seriously look at a surgical option in this pyramid. And this pyramid is shifting all the time. I mean, traditionally, we used to look at surgery beyond 40. But if you look at the recent studies, more and more patients are opting for a surgical management with even BMIs around 30. I'd like to thank you for your attention.